West Yorkshire ICB, and I work in Bradford District in Craven. Just some really minor bits of housekeeping before we start. If you can put yourself on mute during the next hour, there'll be opportunities to come off that and work and ask questions. We'll be recording the session, so if you don't want to be seen within that, turn your cameras off. And there'll be lots of other things going into the chat as well, like links to other bits of work we're doing and so on. We'll try and keep a tab on the questions that are going in there and make sure that we answer them all today. So we've got a really packed hour today. This is the last of our 5 sessions during this Core20+5 Learning Week. The reason why we decided to hold this event was we have a national Core20+5 programme. This is about reducing health inequalities. For those of you that don't know the background to that, the Core 20 is around the most deprived 20% of the UK population. That's about half our population in Bradford. The plus is around groups that are traditionally marginalised or do not access NHS and help and support services. So people from that have had experience through the criminal justice background, new migrants, homeless people. That it's those sorts of groups within the plus group. And then the 5 is the 5 national clinical priorities. So they are around respiratory disease, serious mental illness, cancer, cardiovascular disease and maternity. And we've added adversity, trauma and resilience for young people locally, because that is such a big issue that we think is local. So that's the national background. About 3 years ago, we got notification of funding to set up a Core20+5 programme in Bradford District, which is what we've been doing. And that's what we've been feeding our experience and learning back from you all today. Bradford, as you know, has got really some quite severe health inequalities. We always quote the figure of difference in healthy life expectancy, which is 22 years for women between affluent and poorer parts of the district. And that's just a number, but what that means in real term is that on average, people in those more deprived areas are spending about 1/3 of their life in poor health. And that's the gap that we're trying to close. So we've been feeding back on the clinical priorities, the work in the most deprived areas, and the work with our plus or in health inclusion health groups this week. And this 5th session that we've got today, we're going to try and do 2 things. We've been showcasing work from right across Bradford District and Craven throughout the week. And we've got a presentation. Anna is on the call here, who's going to talk a little bit about the work that's going on in Craven. So we need to listen to that. We'll have some questions, Anna, or maybe at the end, depending on the time. And then we're going to have some overall findings from Core20+5. So myself and other members of the team are just going to give some brief findings on that. This will be part of a bigger report, a REACH report, Core20+5 REACH, that we'll publish later in autumn. And a really important part, and we really mean this, of that report is what's happened this week. So all the questions that have been coming in, the comments in the chat, the things that we've heard from our delivery partners across Bradford, really, really important that they go into that REACH report as well. So this is part of the evaluation, and we haven't formed our overall conclusions yet, but we want to feedback what we've done. So we'll crack straight on. So it's great to be able to introduce Anna, who from Eat, Move and Be Happy, working with WACA Modality Primary Care Network up in and it's a health coaching model that's working up in Craven. So Anna, we've got about 10 minutes for this, if that's okay, and I'll hand it over to you.
Yeah, no, that's fine. Good morning, everybody. I'll just say up front, I will have to leave at 10:30 because I'm rushing off to do some coaching. So I'll try and get through this as quickly as possible. I'm going to try and share my screen. I did say to Sophie that sometimes I have some technical some technical issues, and it doesn't always do it for me. But can we see that?
Yeah.
Perfect. Okay, so let's crack straight on. One of the things that we were looking at, or the primary focus for our health coaching project, which has been running for a number of years now, is just exactly as you said, Duncan, looking at how do we engage with people in those deprived areas. And primarily it was around people with those multiple chronic medical conditions like hypertension, etc. I'm not going to read everything off the slide. And we have been trying to focus on people where they've got comorbidities, but also specifically people who are either older and living sedentary lives, but feeling socially isolated, not just because they're in areas of deprivation, but also geographically, they might not be able to access services locally. Also, we've included the third bullet point there. So people who are living with a BMI that's 35 plus and waiting for joint replacements, usually knees and hips, and because of their weight, they're not able to get onto the waiting list for the joint replacement. So we work with them to help get them moving and as strong as possible, as well as control their weight. So it's looking at things from a number of different factors, I guess. Just to give you a very, very brief background explanation of my background. So I moved into health coaching full-time about 5 years ago, but I've been in this field for about 10 years. But my main background is in learning and development, organizational development and business coaching. So I have a strong coaching background, and because of my sort of interest in keeping people active, I coach netball apart from amongst other things. I fell into, almost by accident, but sometimes these things are meant to be, into health coaching, and have expanded that, which with my business partner is how Eat, Move, Be Happy was born. So I have got quite a bit of experience around coaching in other contexts, which seemed really sensible to bring it into this field. So the question around what we were trying to do with the health coaching project, which Emma, you might be able to help me with this, I think is 4 or 5 years ago that we started, Emma Taylor from WACA, we started to work together. And some of the key points, as I've only got 10 minutes, I've had to try and condense this massively, but the primary focus is we meet people where they are and focus very much on what they can do. So coaching is not about us telling people what they think they should be doing or what we think their goals should be. It is about understanding where people actually are now and helping them to address those barriers. And sometimes it's just the barriers to accessing the support that's available. And often it's a combination of that and helping them actually want to make some change, because often they feel that it's completely hopeless. There's no point in doing anything because nothing's going to make a difference. And coaching can actually help them realise that they do have some choices and they can take that first step. And when people take a step to some sort of change, it helps build that momentum. And I've called it belief, but there's a confidence element in it as well. And if we can get people to experience some of that more positive approach, whilst still accepting that the challenges that they face, because the challenges are very real, then they're more likely to take the next step with either our support at Eat, Move, Be Happy, but often it's beyond Eat, Move, Be Happy as well. We work in partnership with a number of different organisations.
Shall I come in there, just Anna?
Yes, certainly. Do.
So one of the reasons we've been heavily interested in the health coaching concept is in primary care, a lot of people come to clinicians with a fix me attitude. They want help, they want to be given medication, and not necessarily taking responsibility or ownership of their own health. And by working alongside this team here at Eat, Move, Be Happy, we've actually challenged the way that our own clinicians change their language and their concept in terms of having their conversations with those patients to flip that ownership back onto the patient and to help them to accept that they are the total owners of their health, and we can offer them suggestions, but the coaching methodology and the link into preventative health measures has been crucially helpful by having somebody like Anna training clinicians, but also being there to offer that coaching platform through the Eat, Move, Be Happy health coaching programs.
Thanks, Emma. Yeah, I think for a lot of people, when you're in it, when you're in your own situation, you often don't know where to start. And the people that we're talking about have probably tried lots of different things over a period of time, some of which may have worked to a certain degree, but often we don't recognize the things that work. And what coaching, there's a whole spectrum of coaching, and what coaching can do, it can just help people realize that some of the things that they are doing are helpful, and some of the things that they're doing might not be as helpful. So it's what we would call holding people in that space. And it's absolutely what Emma was saying. It's not about us fixing people, because we can't, but it is about helping them recognize their own responsibility and recognizing the support that's available. And if they can get some positive experience of doing some of these things differently themselves, no matter how small that first step, then that's, in my experience, and we've seen it time and time again, that's where their confidence improves, and that belief, so that hopelessness starts to get smaller and they become more hopeful. And sometimes, certainly as a coach, it's just about, as Emma said, it's about the language that we use. It's about how that is positioned with the person, and how the dialogue evolves, so that they feel included in this. It's not being done to them. They have some agency in this process, and that helping them realize that no matter how, I can't tell you how many times people have said to me, well, it's pointless because I'm either too old, I'm too unfit, I'm too something else. Whereas actually it doesn't matter about any of those situations. If we start to make some changes in a more healthful way, it does make a difference. And when they experience that for themselves, it's actually quite special. So we do two different types of coaching using those principles. We have a group approach called Live Better, which looks at lifestyle habits in general, but it focuses very much around eating habits and relationships with food. So it's not about a diet, but it is about understanding habits and helping people understand what are the current habits they have which are helpful and what are those that aren't. And we find that the power of the group is really, really important. And time again, people tell us, whilst they might know this sort of logically, recognizing that there are other people in not the same situation, but similar situations, and learning from them and feeling supported by them and being able to offer support to other people. I think sometimes people underestimate how important those small shifts are, and how people do feel that sense of value and self-worth when they can offer support to other people. So it's looking at it on a number of different angles, if you like, so they can share their own experiences and learning. And it helps people feel that sense of accountability. They can hold each other to account, and they can ask for the support from others. So Live Better is a program that we run. And this is just an example of a client from Live Better, and that just about summed it up for me, because we very much talk about the program as this is not about just the food. It's so much more than that. And she surprised herself by how much she could actually do. And again, that's a really common belief. I can't do that because, and actually, this particular woman, she still comes to our Get Moving exercise classes. So she's completed Live Better as a program. She has made some changes. She's not perfect, but it's not about being perfect. But that just sums it up. And I think Colette's words speak better than mine. I have another example, and this is a great example of meeting somebody where they are. So Mark, who joined Live Better about 18 months ago, actually, he was quite skeptical. And like he said, I went to the chat partly to force himself to interact with others, part of his issue was he was very socially isolated, lives with poor mental health, amongst other things. And again, he was surprised at how much he actually enjoyed that social interaction and how much he got from it. Now, he made some changes, but as these are his words, at the no effort level, ready meals. He was choosing his mixed greens over his chips. And you know what? I'll take that as a win, because it's a step in the right direction. We have a number of different phrases at Eat, Move, Be Happy. Better is better is one of them. It doesn't matter how small that step. When people realise they can make some change, then they're more likely to do it. And that's with the help of coaching.
Anna,
yes.
Anna, sorry to butt in. Do you think you can just start making your final points, please?
I will indeed. So
thank you.
The Fresh Start coaching is the one-to-one coaching that we offer, which is a more personalised approach. And that's around people. When I said earlier that this is not about, everybody doesn't have to be in the same situation, and we're not telling people what to do. So this is a much more personalised, helping people define and overcome whatever the barriers are that they have and start to make those changes. I've got some case studies. I can share these afterwards, but we've taken that approach for the CVD secondary prevention programme that is a new project started. Emma, do you want to share the detail about that?
Yes, very quickly. It's a pilot that's happening for the next year about people who are newly diagnosed with hypertension, and looking at the how we could handhold these people over the year to help them reduce their blood pressure through lifestyle medicine and health coaching, and looking at how various people respond differently to different mechanisms of support. So that just started last night. We're working in an area of high deprivation, two distinct community centres as well, so making it accessible, but also running it through every GP surgery in Craven. So early days, but we look forward to sharing the findings at a later date. Thank you very much.
And the final bit, the key learning for us over the projects that we've run is that it's working with the community links, like Emma said, actually being in the communities and creating those connections and building that trust. Flexibility and approach is absolutely key. There is a structure around the stuff that we do, and being able to flex it to meet the needs of the individual is important. And finally, it's the power of the group. If we can get people, if we can signpost people into different local community support groups, then we find that they thrive more. Okay, I'll come back and stop sharing. Has anybody got any questions?
That's fantastic. Thanks, Anna and Emma. I love that. The power of the group, that's the key message for me. I thought that was really important. And then the other thing that's going to go into my culinary expertise is mixed greens over chips. I love the sound of that. That's something for the weekend. I think if anybody's got any questions and they want to put them in the chat, I'm just seeing if we've got any immediate questions. If you put them in the chat, and we can, I know you have to leave, Anna, but that was absolutely fantastic. Thanks for that. And sorry to cut you off halfway through as well. We've got quite a lot to get through. So what we'll do now is, one of the things that we wanted to do was to give some headline messages back from almost 3 years of work now. We've got over 70 different Core20PLUS5 projects going on across Bradford District in Craven. You've just heard one of them. There's so many great examples. They've all developed in different ways. Some have been really, really successful. Others have had difficulties getting off the ground. And there's no point in us pretending that everything has been perfect. I think things take time. We've heard from our communities that it takes time to work with people. We need trust, we need time, and it takes time as well to develop these projects as well. So what we're going to do now is we've tried to summarise what we think are the key messages and the main impacts. So we've got some slides from the team that I think 2 or 3 of us are going to contribute to, that I believe if you can share those now, Sophie, and put your questions in the chat. I think Joe and Jill are going to start off, and then I'm just going to finish off with a few key messages at the end.
Okay, so I think it's me that's kicking off, isn't it, Joe? I'm gonna go through these as quickly as I can, I think. So yeah, so absolutely fantastic learning that we've heard through this week, and we're really keen that we gather that together and we put it into the into our impact report, which is coming in the autumn, which Duncan has already mentioned. But with a view and an eye on the future, we have been thinking about our programme and how impactful it has been, and what the potential might be for the future moving forward, as it's defined in the NHS plan, and what future commissioning intentions may be. So we've been thinking about the programme in terms of how effective we feel our interventions have been, how well it's focused on inequalities, the kind of interventions we've got, so whether they are purely thinking about preventing illness or whether they are diagnosing underlying health conditions and supporting people with those, whether there's any evidence of cost effectiveness and return on investment, and what does that look like? What does effective look like? What does good look like? And whether we've had any impact on the clinical outcomes. If you could just move it on, thank you, Sophie. So to do that, we've used a very defined methodology, and we've assessed all our interventions in the programme against a set of criteria which were designed to help us to think about those elements. So effectiveness, how well an intervention's been implemented, how well it's addressed health inequalities, whether it's acceptable, and how connected it's been. And we've also categorised those interventions into the primary and secondary prevention group, or whether they do both. So sorry, I've lost my thread there slightly. So we've done that. We've assessed each of the interventions, and we've done them individually, and then we've done them as a group, and we've come back to moderate those as well. And we also categorised each of our interventions into clinical priority areas, so we could determine the impact that they've had against each of the clinical areas. So if you could just move on, please, Sophie. So thinking about effectiveness and inequalities in particular. Those interventions that were able to demonstrate that they'd absolutely delivered against the outcomes that we'd identified in our theory of change and logic model were the interventions that we scored the highest. Interventions that scored slightly lower, so maybe a 3 or a 1 or a 2, was dependent on how well they had delivered against the outcomes that they'd set out to deliver as an intervention. And that was done at various levels. So those that scored a 3 were those that had delivered against all the outcomes that they'd set out to do. And those that scored slightly lower were ones that maybe hadn't delivered against all their outcomes, but that we recognise that there were lots of reasons why that might have been. But nevertheless, we had to think about interventions delivering against the context that we have in our programme and what our programme has set out to do and the objectives. And then thinking about the inequalities, it was about how well those interventions were reaching into those communities, so the Core 20 and the Plus communities, so the IMD 1 and 2 areas. And also the Asian minority ethnic groups as well. So those that scored the highest were the ones that were absolutely doing that, but that had also impacted against the clinical priority. And then the ones that scored the 3s were the ones that had absolutely impacted on those populations, but might have been a little bit more preventative in their nature. And it's worth saying that the ones that scored lower on the inequalities were largely those that were located in areas of relative affluence. So it's very difficult for them to be able to work with those core populations. But again, we were thinking about the programme and what it's set up to do and the parameters around that programme and the outcomes that we were wanting and the change. So it's also quite important, I think, to note that this assessment is purely within the context of our programme. So if you're thinking about the future, and future commissioning and future commissioners need to think about the outcomes that are specific to them and how these interventions might fit in and deliver against the outcomes that they want. This is in no way, many of the interventions that we've got, nearly all of them are effective services, but this is about how it's addressed our theory of change and logic model. And just one more slide, I think, which just, thank you. So on this slide, you can just see on the left-hand side, these are the scorings for the inequalities. So thinking about the future, we're thinking about how well interventions have addressed inequalities and what type of intervention they are. And so we can see that we have about 13 projects that scored the absolute highest on the 4, but the majority of our projects, over half, scored a 4 or a 3. So those projects were absolutely impacting on those key core 20 and plus populations. And you can see from the right hand side that we have a fairly even split between those projects that sit primarily within primary prevention focus projects and those that have an element of both, which is the blue section. And then we do have some projects which are just secondary prevention projects. So by thinking about both inequalities and the type of intervention we've got, we can start to think about what those, how that fits into any sort of future commissioning in the you know, how these kinds of interventions might deliver against any future hyperlocal models for delivery for addressing inequalities. And I'm going to pass over to Jo. Thank you.
Thanks, Jill. So just a few points from me. Most people here on the call today will know that I've been leading with the team the Core20PLUS5 work, and we've had these 73 projects across the footprint, which has been absolutely amazing. We set out 3 years ago to try and make sure that as many of those were in areas of greatest deprivation. So on the map here, we have the darkest red areas, which are our lower super output areas that are of the greatest deprivation in our district. And the lighter areas are our more affluent areas. We set out very at the beginning with the onset of proportionally distributing our funding. So those of you that were with us on Monday will have heard how we set up. That means areas of greater deprivation got more funding allocation. They also got more support through my team here at the ICB and the team of Reducing Inequalities managers. And this map really just reassures us that what we intended at the beginning has actually taken place. So the green dots show you where our activity has been. The bigger the dot, the more activity has taken place in that area. So we have high concentrations in areas of greater deprivation. And as Jill alluded to, we really set a challenge to our more affluent areas. They did get funding, but obviously the populations aren't there in the greater number. So it is really difficult in those areas to reach into our core 20 plus populations. So yeah, we've shown this as a bit of a celebration of our success, really, that we have absolutely been in those areas of greater deprivation. Thanks, Sophie. So let's just hone in a little bit on what we've learned and some of the themes from the projects that were in that 13 that scored 4 for inequalities, but also those that had some local evidence. So we've divided them here. The ones with strong local evidence are those where during the process that Jill just spelled out, we found that actually they were focusing on inequalities and had shown effectiveness. And we've got some really, really good strong themes here. And those of you that have been with us through the week will have already heard some of the projects that fit into these themes. And if you haven't been here, you can see them on catch up when the videos are on YouTube. But we've had examples such as KCAM telling us about how you reach with health coaching and health messaging into targeted communities. We also heard from the Anchor Project and the Vulnerable Migrant Project that's very much about health literacy. And that's been a running theme of those things that have been most focused on health inequalities and have also been effective. We've also heard from our community health check model, which has had great success in reaching into communities that wouldn't necessarily access their NHS health check through standard models of care. Then we've got all of those projects that have shown some evidence, and for us that is good enough because actually this is a massive challenge, and you'll see in a moment why I say that. But we've got all of those projects that have scored 3 in our process, and they're things that we've seen throughout the week as well, such as the family crisis intervention from BCADS that was showcased yesterday, some of our work around maternity circles, And actually, some of the reason that they haven't necessarily hit the fore is that they've been in areas of relative affluence, or they've actually picked a priority that isn't directly in our core 25 clinical areas. And that makes it very difficult, actually, to determine that they are focused on health inequalities and making that greatest impact against our clinical outcomes. So we've got loads of themes, we've got loads of learning for the future. Duncan's going to come on to that in a moment, but just one last slide from me, Sophie, if you may, which is just to acknowledge that the Core20PLUS5 programme, if you just move on one, Sophie. The Core20PLUS5 programme has been an absolute mission, and we're massively grateful for everybody here today that's taken part in it with us so far as it moves into the future. But it has been challenging, and it would be remiss of us to not actually focus in on those things, because actually they provide us with learning from the programme. So we know it's taken time. We know you have to work really hard when you're trying to balance co-production with communities with evidence-based programmes. They aren't necessarily aligned sometimes, and it's really challenging. We also need to find community infrastructures that are mature enough to actually make decisions. That is absolutely no criticism of our community partnership infrastructure, but actually the people that are coming around the table aren't necessarily being asked to make these kind of decisions on a daily basis. So it has been a massively steep learning curve for many of our communities. We also know, and many people here today all know, the challenge of monitoring this kind of programme of work. So everything Jill has just said has completely relied on us being able to understand who it is that's attended our projects, who's come through the door, who are they, what are their characteristics. And actually that's really challenging. It brings about a whole burden for our projects that actually sometimes feels too difficult. So we've worked really hard with our projects. And some of that ability to be able to tell what our projects have been doing is hindered by that monitoring and data collection, which we appreciate. Capturing everybody who walks through your community health centre on a daily basis is really tricky. We also know that there's been a team here at the ICB that have been supporting this programme, and it is administratively takes a lot of capacity. So we've had a lot of us working on it. We know it just doesn't happen. We know that actually working into the future, we can't expect to wave a magic wand and get a programme like Core20PLUS5 that keeps going into the future without that infrastructure behind it. But we also know that the ICB is going through changes that Duncan will talk about shortly. So we have had challenges in delivering the Core20PLUS5 programme, and we've celebrated it all week about what we've managed to actually do. But that does not mean that we've forgotten how challenging it is for everybody, and we're massively grateful for the effort that everybody's put in. That's it from me. I'm going to hand over to Duncan, who's going to take it from here. Thanks, Sophie, if you move on.
Thanks, Joe and Jill. So I've got a few slides just to finish up. The first one is about return on investment. We have to think about return on investment. We have to think about budgets. And we were not collecting the enough information to be able to do detailed health economic analysis of all these 70 projects. We didn't want to ask for that much data. We haven't got the resources to do that. But what I thought was interesting was if we can look at the types of interventions that our partners are delivering and look at the international and national evidence base around return on investment to see what the research tells us, to see whether community partnerships have actually been investing in what we think were the right areas in terms of return on investment, in terms of return back to the NHS, return back to social value, return back to individuals. So what we did a quick literature search and looked for papers about public health interventions, where there was some health economic evidence and where there was some estimates of the return of investment. And so we found although we've got about 70 projects, we've got about between 50 and 60 different types of interventions. And what we found that the return on investment across about half of those 30 interventions was estimated to be about 7.62 or £7.62 return on investment for every pound invested. That is an estimate, and that is where we've tried to match the evidence base about interventions to specific interventions in Bradford. Sometimes that's difficult because we've got mini hubs, we've got very, very holistic support, so it's very difficult to actually narrow down what the intervention is and find evidence about that in some areas. But what we have found is that community partnerships have generally invested in cost-effective and evidence-based interventions and have followed the advice and have used the guides and the research base and the guides that we sent out to them right at the beginning of the start. So The other thing to say is lack of evidence doesn't mean lack of impact, and it may just be that the evidence base isn't developed in some areas. It's very good for clinical outcomes around SMI, cancer, cardiovascular disease, but there isn't so much health economic evidence around some of the more cultural aspects. So that's something that we can recommend as well when we talk to research partners. Okay, next slide, please. So what I want to do is focus on some sort of key messages and detailed messages, and then sort of think a little bit more about the broader impact of Core20+5. So just looking at what's happened, we've had over 15,000 contacts and counting in over 70 different projects across Bradford District and Craven. It's absolutely incredible effort by local providers, grassroots organisations and community partnerships in getting that going. We've got a breadth of learning, we've got an evidence base now to support that left shift in NHS funding. And I know we see prevention, we see inequalities all over budgets, all over strategies, but we don't necessarily see that left shift into budgets. What we have got now, and what we need to just keep making that message, is that we have got a very strong evidence base emerging from Core20+5 and from previous work that we've done, such as reducing inequalities in communities. So that's the evidence base. In terms of communities, and particularly around community partnerships, I think what we've been able to do is harness local talent, handing some funding, some autonomy over with some co-production with the ICB, but essentially having some more autonomy of decision-making around funding over to community partnerships. I've been able to really identify local needs, been identifying and using those local community assets that we just don't have the detailed knowledge about within the ICB. And if there's one thing that I have really learned this week, it's that about trust and time. That has just come back from so many presentations that we've heard about this week. Trust plus time equals impact. That's the thing that I'm really taking away. Support to navigate that complexity and support interest in community settings, really, really important. And then finally, about innovation. So proportionate universalism. So this is Michael Marmot's phrase, which is really about, we have to take a population health approach and support everybody's health, but we have to target our effort in areas with greater need. And we need to resource at scale, but we need to intensify our resources in areas of higher inequalities. And I think you put a question about this in the chat, Carlton, and about how we're thinking about this in the future. Our thinking is that we have to go even further in targeting the inequalities budgets, which aren't huge. The inequalities budget we have to go even further in targeting needs in deprived areas. But what we have found is the programme has led to, and it's catalysed match funding. We've got external funding from the Burdett Trust around maternity. We've had external funding from public health around some of our work with children and people's mental health and adversity and trauma and resilience. So it's led to more funding and more interest in the programme as well. And it's also acted as a learning network. So some of the things that have come off the ground, like the community health checks and the maternity circles, are really good examples of things that were funded within Core20 budgets, but have then sprung up around the district as well, outside our budgets. So it's that expansion of learning that's really, really important. Next slide, please. So one of the things that we do have to do, though, is look at the overall picture. So Core20+5 is part of a much, much bigger partnership effort to reduce inequalities. We aren't the only show in town. There's lots of other people working on this. And it's unlikely that a budget of 1.22 million is going to affect the overall population health trends of 660,000 people. But we need to look at these to really see where some of the areas we need to work harder. So this is a summary of the whole population. I'm just going to quickly sort of pick it out. I mean, I've done a bit of a RAG rating on that. There's it's a really mixed picture. There's some real areas of improvement. Percentage of mums booking earning to maternity before 10 weeks is improving. There's a very small inequality gap there, but our infant mortality rate is still high in Bradford District, so we have to keep working very, very hard on this area. Annual physical health checks for people with SMI is increasing. There's no inequality gap here. A lot of our work has been much more upstream than SMI, and the point that I want to make here is to really shift things. You have to have sustained leadership. We've had an SMI physical health check group. We've had really good leadership from clinical leaders for years on this, and that is the main reason why this is going in the right direction. With vaccination, it's a bit of a mixed bag. There were things in the paper this week about vaccine hesitancy for baby IMS, But in terms of flu vaccination, that's improving. But pneumococcal vaccination, which is really important, particularly for older people in preventing hospitalisation, the inequality gap is widening there. So there's still work to do. With cancer, screening uptake is lower in deprived areas for all 3 of our major cancer screening programme. But there's some slow improvement, and there's been improvement in bowel cancer screening over the last couple of years, but there's a bit more work to do there. High blood pressure, the cardiovascular disease, the community health checks identified a lot of people with high blood pressure, some that haven't even had any tests. So there's a big inequality gap there. Cardiovascular disease and how that interacts with diabetes, chronic kidney disease and so on is a really, really important area of multimorbidity for us to work on. And then finally, smoking. Smoking is still the biggest killer in the country. There's some good news though. Adult smoking rates is coming down. Smoking during pregnancy rates are coming down. So there is some good news there. Okay, next slide, please. So just thinking a little bit more now about broadly, what's coming over the horizon? Well, I think Ashley's on the call. We'll hear a little bit about integrated neighbourhood health, but integrated neighbourhood health is not the only show in town, but it's a big show in town. And there's 3 rings in the national model around that. The inner ring is more about people with higher needs and about hospitalisation and care homes and preventing people improving their health there. And then there's a really big ring around strengthening primary care and working with primary care. And then there's a really big ring around connecting people to wider support services in the community. And I think what we have with Core20+5 now is a really good model that really can speak to those 2 outer rings and support those. Okay, if you want to have a look about this, if you Google integrated neighbourhood care, you'll see the government guidelines and just have a quick look at that. Okay, next slide, please. And then the other thing is the 10-year health plan for England. So we've got the 3 shifts. I think from sickness to prevention and from hospital to community speak for themselves in terms of what we've heard this week. The one that we probably haven't done much work on in Core20+5 is from analogue to digital. There's many types of digital exclusion, whether it's through digital poverty, lack of digital literacy, confidence, fears of just going on the internet and getting into digital systems, and then existing disabilities that may make it more difficult for people to access that care. There's a lot coming over the horizon around digital healthcare, and it's something that I really want to stress that we all need to think about and think about within your projects as well. The 4th shift that I've put in there was Dirk Dougal's challenge to us on the first day on Monday, is where is the 4th shift on tackling inequalities in the NHS plan? It's not there, I'm afraid. Inequalities are mentioned, but the detail of how we reduce them is not big. So I think we have to think about that. We have to assume we have to go from equality to equity based on need. That's the big 4th shift. And then the other thing is really around health creation as well. Health is created in communities, and the co-production and the partnership working that we've shown during Core20+5 really helps with that. Okay, next slide, please, Sophie. So this is where I start to get a little bit poetic. What we've tried to do with Core20+5 is really, we shared some of the wonderful work over the week, but let 1,000 flowers bloom. And what we really want to do is make sure that those flowers do bloom. And what we want is a towering oak of reducing inequalities over the entire system that dominates our thinking, not just about those small projects, but just dominates the way that we do everything in Bradford District and Craven. Because the dark clouds around our budgets are always going to be there. They're always going to be hovering. We live in a cash-strapped environment, almost in perma-austerity. So we just need to keep making the argument and keep putting our foot on the gas for that. Okay, next slide, please. And the other way of looking at it, and this is my very, very complicated Excel slide. It took me hours to do this. I was interested in what proportion of our overall budget Core20+5 covers. We've got about, I think it's about 1.3 billion on health and care spend across Bradford District and Craven. Our annual budget that we've used working with community partnerships is about 1.1 million, so it's about 1,000th. When I put this into Excel, it didn't even show on the chart. It was so small. So I put that dot in myself, I'm afraid. It's a bit of a lie. It's not really even an Excel chart. But the point that I'm trying to make, if you just go to the next slide, Sophie, is that what we have to do is we've essentially seed funded lots of really, really good programs. And what we have to try and do now is make sure that reducing inequalities is just the way that we do things across everything. Okay. Next slide, please. So I think this is the final slide from me. So system impacts. What we've seen, and if we think back to 3 years ago when we started working with community partnerships, is I think Core20 has acted as a little bit of capacity. Community partnerships are all in a slightly different place. I think what we've been able to do is see a supporting environment for a maturity of community partnerships, increased skills in local decision making, and deciding on prioritising grant making, evaluation, value for money. What we're showing the value for money analysis is that there is value for money in a lot of these programmes. And what this gives us is a really strong message to be able to articulate with our leaders, with the people that we work with, the impact of a hyperlocal approach, and the fact that it isn't necessarily what people are doing, it's how they're doing it. It's the scalable approaches of saying we can get these big national NHS programmes or other programmes and make them work in Bradford, and we know how to do that. And I think that's what the system learning is. And then finally, sustainability. So what next? Well, I think we have to move with the times. We have to think creatively about what's coming through the 10-year health plan. It's got a lot around prevention and community shifts in it. So we have to think about that. We have to think about integrated neighbourhoods health. So you've seen those 3 concentric circles. There's a lot of work that's going to be going on in the ICB. And if you think about those 2 outer rings that I've described, that is what we have to do. We have to operationalise Core20+5 now within that new integrated neighbourhood health model. And finally, I think one of the things that we did struggle with a bit at the start of the programme is this slight criticism that we were being a little bit too top down, or some people thought we weren't top down enough. How much discretion did we want to give to community partnerships? I think what we've shown is that you can have both. You can have a bit of a hybrid model. What we've tried to do is bring data intelligence, some support around evidence base, but what we've actually got is a co-production approach between CPs and ICB staff. So that's the model that we're really thinking about at the moment and about how we take that forward. Okay, so if we want to stop sharing the slides now, thanks, Sophie. We've got a few questions, I think, that are coming up. But what I wanted to say to everybody, firstly, I've just got a few thank yous. I just wanted to say thank you for the creativity and the positivity in the way that all the community partnerships and all the providers have really taken this work forward. It's been an absolute, really has been a joy to see the programme develop. So I want to say thank you. And another thing, because I want to have time for this as well, is unfortunately somebody who's very special to the programme is leaving us at the end of next week. I can't believe she's deserting us. Jo Houses is unfortunately absconding to the local authority. If we could bring on, if this was face to face, we would bring on a big bunch of flowers, Jo. But I want to say personally from me and the team, thank you very much, because your energy and drive has really got this going as well. And for once only, I want to ask everybody to turn their microphones on rather than off. And I want a round of applause for Jo and all the providers that have made Core20+5 a success. So make as much noise as you want, whoop, holler and clap. You won't get many chances to do this. So thanks to everyone. It's a round of applause.
We love you, Jo.
We do.
Okay, thanks for that. Cameras, sorry, microphone's back off again. Right, we've got about 10 minutes left. And I'll bring Ashley in a minute just to say a little bit about integrated neighbours health. But has anybody got any burning questions, comments, or particularly advice for us about how we try and take this Core20+5 programme forward? Just having a look. Have we got any hands up? Was there any? Oh, Carlton.
Yeah, I've been a bit quiet in the chat, so I thought I'd speak as well. So we got loads of fantastic programmes working across the district. All of them are about to finish in 6 months. We're generally working on 12-month contracts, people pulling these things together, getting them up and running, getting all the reporting back, and then wondering whether they've got a job in 6 months. Yeah. Is there any moves to make opportunities to well, we've done it a bit in the last 2 years, I guess, opportunities to make some of these projects a bit more mainstream, and that will then enable us to scale them up across the district as well?
Yeah, so it's a really good question. So at the moment, we're all having conversations about options for supporting community partnerships in the new world. As some people will have heard, some won't, but all ICBs across the country have been asked to find a 50% staff cut as well. So we need to think about a sustainable model for community partnerships, not just in the things that are funded, but how you keep going as organisations as well and decision-making bodies. So we're looking at that, and then also having conversations around the budget for Core20PLUS5, because we think we've got the evidence here to make a really strong case to continue with it. There might have to be some changes in the way that we operate things, but moving out of a cycle of very short-term funding is something that I think we need to do, and we need to think more about the sector as a whole. So I can't give you any definitive answers on that at the moment, Carlton, but we're fighting really, really hard for the budgets, and our deadline is really, because I know that you all will need at least a quarter or 3 months and over to start making those decisions and thinking about staff, and you'll be thinking about it already, I know. So we're working really hard on that at the moment to get that through the decision-making process within the ICB, so we can get some certainty back out to you all as soon as possible.
That's great to hear, and thank you, and thanks to the team for the rigour on the information and evidence that you've forced us all to do. But yeah, having that as cases we can present to people to justify the work and show that it works is invaluable. So thank you all very much for that.
Thanks, Carlton. Toshal, I know you've got your hands up, but just quickly before you do that, I just wanted to, Ashley, are you on the call? I just wondered if I think you've got a slide that just shows what the challenge is going to be for us around integrated neighbourhood health. We thought this would be useful just for people to see the sorts of things that you're doing already and how that fits into integrated neighbourhood world for future.
Yeah, it's quite a busy slide. I suppose I really like the 3 circles Duncan shared. I think they're quite familiar because it's a really, really, really broad agenda, and the government and I think the leadership in Bradford and Craven want multiple different things to happen from integrated neighbourhood health, depending on who you ask. So I think there are certainly people in the government who are very interested in how does neighbourhood health stop people going into A&E, and then obviously there's something about how do we support people to live healthier lives long term and support all the great things we've heard about today and on the previous presentation. So part of it is trying to chunk up what's an enormous agenda, just trying to do loads of different things in things that's manageable. So what we've got there is we've got our healthcare and wellbeing strategy, which some of you may have seen was published in September, and that sort of sets out, it has a chapter on neighbourhood health, but neighbourhood health runs as a golden thread throughout the whole piece, and Duncan's reflected on this. And I guess one of the things that we've got to do, and it links to the conversation Duncan and Carlton have just had, is we've got to navigate quite a complex landscape now. I have lots and lots of national asks. We get asks from West Yorkshire. Duncan's referenced that we're also going through a period of change, and future budgets we need to work through that collectively, and that's something Duncan and I are working on. So it's a new world we're moving into. We've also got some of you will be aware we've got a new provider collaborative. So that's a collaborative across our 3 trusts, our 2 local authorities, our VCS sector, and our general practices, and that's still evolving and emerging. So there's lots and lots going on, but we do recognise there's a need to give sectors and different teams some certainty where we can. We don't always have certainty ourselves. So I'm not going to talk through this slide. It just conveys there are multiple components. There are quite a lot of people working on this, not just myself, not just Duncan and Joe and Jill and others. It's a multiple effort depending on which lens of integrated neighbourhood health you look at. So I've got colleagues that work on intermediate care, that's part of neighbourhood health. I've got colleagues that look at, for example, long-term continuous management, as Duncan and Polly do. We've got colleagues that work on sort of clinical pathways. It's vast, it's broad. So we're trying to work out what does that mean in terms of multiple programmes of work? How do they link together? And given, as Duncan says, the ICB will shrink significantly at some point, it can't all fall in the same way it can't fall to any sector. We're looking at, Duncan and I are looking at how we can bring maybe some of our more traditional NHS partners a bit more into this side so that they're seeing that this is really important part of their agenda too. So Duncan, I think for reasons of time, that's probably all. Just one more slide. There's one more slide just to share a bit of a heads up. So some of you will be aware of this, but the government has launched something called the National Neighbourhood Implementation Programme. And this is intended to be a multi-year programme linked to the 10-year plan. And there was a process for different parts of the country to apply for this in August. And Bradford District and Craven Health and Care Partnership did apply. And we were successful as one of the 43 places in the district, which is great. The only thing is there's now lots of work to do, and NHS England and the Department of Health almost want it all done yesterday. For this year, because it's a multi-year programme, so what we're involved in this year is a bit of work around accelerating models of care for adults with multiple long-term conditions. And NHS England have selected a number of areas of the district where they want to do a more intensive focus on that. So it's still an evolving picture, very rapidly evolving, but there's a website link there. It's well worth having a look on it. It'll describe what the programme is nationally far better than I can in a couple of minutes. And we're working on what that means for Bradford and Craven now. Our participation was announced at the start of September, so it's still really early days, but we've only got a year, so we've got a lot to do in the next year. Thanks, Duncan.
Thanks, Ashley. That was great. So I've just advised everyone just have a quick look at that and see if you can think about how you fit into it, because we will be wanting to use the learning from this work and get in touch with everyone. And we've got a couple of minutes left. Toshal, did you want to ask just a really quick question? Sorry to cut you off before.
No, it's fine. I've just put it in the chat. Just wanted to give the feedback regards to program, the work that we've done with colleagues on ground, and just wanted to say thank you. And a genuine partnership on ground was something I think everybody valued, to have that frontline connection with that person in the area locally. So I just wanted to say that.
Thank you. That's really kind. So I think we'll bring it to a close. Our email address is ria@bradford.nhs.uk. So if there's any other questions, just get in touch. And also to say, this isn't the end of the project. Carlton's question is the big question at the moment, and we are, we're going to take this forward. But this was just we brought this forward partly because Joe's leaving, but partly because we wanted to get all these findings out to people and show you the impact that your work's been having. So we'll share the REACH report with you all. That will go out in our bulletin. If you're not part of our bulletin, I don't know if we've mentioned it this week. I think probably only about 50 times. But if you want to join the Reducing Inequalities Alliance bulletin, and that's on the website, drop us a line. So thanks to everyone. Have a great weekend and go in peace. See you all soon, hopefully.
Thank you for joining us all. Bye.